Good morning and welcome to our monthly live webcast from Mount Sinai Hospital in New York City. I'm your moderator, Vishal Kapoor, and with me is my good friend and colleague, Dr. Sardar Farhan.
Hello, everybody.
We'd like to welcome everyone to our session this month where we're going to be showing another interesting case with the goal of learning and teaching and, of course, having some fun online. Before we go on to our to the room, just wanted to update you that our cases from today and from the previous sections are available on our website, ccclivecases.org. Please be more than happy to go into the websites, look into our previous cases, leave comments, concerns, or questions, and we'll be more than happy to communicate. So without further ado, I'm going to welcome PK and the team. Good morning, PK.
Good morning. That's it. Good morning, Vishal. Again, thank you so much for everybody for joining us. So we're starting a nice case in the new year with a nice how can you say decision-making case. I wouldn't say technically challenging, but definitely decision-making wise. And I think our goal here is to talk about access, and our goal is to talk about treatment options for patients who've had bypass surgery. So let's talk a little bit about this case. First of all, I hope everybody's healthy. I know there are parts of America which has now the COVID boom. So therefore, I hope everybody's safe and healthy wherever you may be watching from. But I'd like to welcome our team. First, I'd like to introduce our lead nurse, Elizabeth Holton. Then our Karthik Guja right next to me, who's our associate director of endovascular interventions. Then we've got our two new fellows this year, which I think is really incredible for our program. Well, today, so they're taking turns in the live cases. Today we have Raman Sharma, who is our interventional fellow last year, who has been part of our team since last year, but however decided to do a dedicated endovascular year, and we're thrilled about that. Nice. And then next to him, we have Ranil Lascano. As you know, we call him Dr. Ray, and he's been here for a long time with us. And then we've got Cristobal, who decided to make a guest appearance today. So we've got a very exciting case about access, Vishal and Sardar. As you know, access controversies and access decisions are a major part of what we're doing here in PAD. So we're going to ask Karthik to stop for a second, and we're going to ask Raman to go ahead and start the presentation. And after the presentation, I want to have a little bit of discussion, and then we'll take it from there. So Raman, you want to hit it?
Of course.
Slides, please, guys.
All right. Good morning, everybody. So today, as we are discussing, is going to be more of a discussion about access, and this is more of a unique situation. So we're going to be talking about a transradial approach for a common femoral artery intervention that involves a Fem-Fem bypass.
Slower.
Next slide. So this patient, he's a 70-year-old male with a past medical history of hypertension, hyperlipidemia, asthma, non-insulin dependent diabetes, CKD stage 3, creatinine is at a baseline of 1.8. He has heart failure with a preserved ejection fraction of 55%, MGUS, also a history of CAD, noble, he's status post-cabbage, as well as PAD, as I mentioned before, with a Fem-Fem bypass, who presented with lifestyle limiting claudication that has progressed to pain at rest with Rutherford 4. This past surgical history, some more information about the cabbage. In 2007, he had a lima to LAD, and now he has an occluded vein to the RPDA. In regards to his PAD, he's had bilateral iliac stenting that was complicated by left common iliac occlusion, which is then status post right to left Fem-Fem bypass, again in around 2007. And he's had a repeat right common iliac stent PTA in 2015. He's on maximal medical therapy with aspirin, beta blockers, lipid-lowering agents, ACE inhibitors, as well as Xarelto 2.5 milligrams BID for the PAD indication. Next slide. For his non-invasive testing, he got himself a lower extremity arterial duplex that showed a 50 to 99% stenosis of the distal right common femoral artery with a maximal PSV of 398 centimeters per second, which was immediately proximal to the bypass graft, as well as showing what we previously knew about the left common iliac stent that was occluded with retrograde flow within the external iliac on the left and antegrade flow resuming distal to the distal anastomosis of the bypass graft. His ABIs were 0.98, but he was unable to perform any exercise due to his claudication. Next. So here we have his ultrasound images. On the left, you see the color Doppler, and you see a good amount of aliasing happening right at that level with the Fem-Fem bypass going up and the common femoral having that lesion. You see a notable decrease in your overall color spectral Doppler. The B mode on the right, you see again, you appreciate this lesion that's immediately proximal to that Fem-Fem bypass. Next slide. And for the PSVs, you see very notable high and a maximal systolic peak of 398 centimeters per second. Next slide. And the recent angiograms, it's a little bit difficult to appreciate here given the size of the image, but we'll have more pictures in our angios coming up. But immediately proximal, you see a little bit of a notch that is right proximal to that anastomosis of the Fem-Fem bypass graft on the right CFA, and an aortogram of the pelvis you see on the right-hand side shows the completely occluded left common iliac artery stent. Next slide. So
why don't we stop here, Roman? Why don't we come off the slides and let's have a discussion before Roman goes into his full presentation. So let's talk a little bit here. I mean, let me go over before we do anything. Let's talk a little bit about accesses. So Vishal, Sardar, Karthik, we have a patient who has a right to left Fem-Fem bypass, who's a severe claudicant. And again, I want to compliment our vascular lab. I mean, the pictures they were able to get to really demonstrate that stenosis is really phenomenal. Because when you look at this, just by looking at the ABIs, you would think that, well, why is this guy claudicating? He's claudicating in some other way. First of all, Vishal, this question is for you. Why do you think he's claudicating? Why do you think he's claudicating?
Well, I mean, he has a significant occlusion in the right common femoral, and then there's a Fem-Fem bypass graft effect that well usually takes off distal to the occlusion per se, and that's what it clearly shows. So I think it's just because the one vessel is feeding the two legs. So the proximal lesion is like you're holding the neck, and then blood going down the ipsilateral way as well as the contralateral to the Fem-Fem is significantly compromised. And I think that's what's causing driving the symptoms.
So I think for lack of a better word, it's almost a steal from the left,
like
right leg.
Yeah,
so
exactly.
Basically it's a steal. So what's happening is when he's ambulating, his left leg is really stealing a lot of blood from the right leg. And so on and so forth. So right now, so you've got that as the mechanism. Sardar, what do you think is the mechanism of injury here?
I believe it must be reaction post-surgery and progression of PAD, the natural course of PAD as well. So it's, I think, a combination of both.
Right, because I mean, Raman, the surgery was when?
Around 2007.
So 2007 surgery, so the guy's been doing well. Then he develops this problem throughout. So it's not an acute surgical suture injury or something like that. So, already you can understand that the mechanism of surgery, of injury is probably a combination of atherosclerosis and as well as progression of the atherosclerosis. So now I want to ask all of you the question, like, the reason we're presenting this case, and I think Sardar and myself talked about it, is that, there's been a lot of transradial peripheral interventions, and one of the things that worries us as a high volume center is that what are the indications for transradial interventions, and what are some of the challenges? So Karthik, what do you think some of the challenges of doing transradial intervention may be, or what do you think some of the advantages of doing transradial intervention?
Personally, I do all coronary interventions as radial, so I think that's probably the reason you diverted the question towards me. But I would say doing peripherals radially is not the best way to approach peripheral angiograms. The reason being, the risk of stroke is not zero when you do radial intervention, especially when you're doing with a regular diagnostic catheter, your risk is about 1 to 2%. So if you're putting a sheet across a radial intervention, and everybody knows peripheral interventions are a little bit longer interventions. So you're putting a sheet across the vertebral, preferably everybody does it through the left radial. So vertebral, subclavian, and the sheet is sitting there. So the biggest risk is stroke, which there is no reason to take in a peripheral angiogram if you do it from femoral or if somebody approaches pedally, which is literally zero if you do it through the. So the biggest risk is stroke. Second risk is again spasms. That's again with any other radial intervention, but more so with peripheral angiogram interventions because you're putting a sheet across it. But that's the two biggest things I think will be a big drawback. And all, of course, radiation, huge amount of radiation for the operator, because you're over the left arm. Again, if it's a CTO you're dealing with, it's very cool to do it, but it just adds so much more radiation to the operator over time, especially in a high volume center like us. Getting so much radiation is not the best thing to do.
Vishal, anything you want to add to that?
No, I mean, I think Karthik is right. It's just about assessing the anatomy and what we are focusing on. I mean, if I'm trying to focus on a proximal lesion, let's say CFA iliacs, then I'm restricted to either a femoral axis, but not in this case. Then I'm more committed to my radial brachial axis. If I'm restricted to my proximal SFAs, I could go either ways, because remember, when you're treating bigger vessels, you require bigger devices, bigger balloons, bigger stents, and bigger salvage. Let's say, God forbid, you perf. You need deliverability of your bailout strategy. So I think one, we have to, I'm sure you're going to discuss, we have to strategize what area we're fixing and what's the approachability. So for me, if it's SFA, CFA, and down distal into the SFA, I could go either ways. If it's more iliac, I'm not comfortable doing transpedal because I want to have my plan B ready, which through pedal you could have restrictions.
You
So
mean transradial?
Transradial.
Transradial.
Yes, transradial. Yes, correct. Sorry. Exactly.
Well, it's interesting because, one of the things we did was we spoke with the Gore people who actually spoke with our Terumo people. And, one of the things is planning the cases, right? If something goes wrong, what are the things we can do? And you're absolutely right. There are some sheet size limitations. And I think in terms of device delivery for bailouts, that needs to be considered in any case. I mean, the advantages of transradial, as we know in the coronaries, one is, less vascular complications. Right. Two is early ambulation. 3 is obviously patient comfort. Obviously, beyond that, in the coronary stuff doesn't really apply to the peripheral stuff, right? Yeah. So when you look at in STEMIs, mortality benefit, stuff like that doesn't really apply. But I think at the same time, I think we need to really look at all of the entire case, like you guys have both done, before we say let's go radial, let's not go radial. So looking at this case. And we obviously have chosen, decided to go radial. The question is, I want to know what other approaches could we have done to treat this patient? Because I'd like the audience to kind of understand our decision-making process as why we decided to go left radial. Karthik went over why we decided to go left radial rather than right. But what are the other options here, guys?
There are only two options, right? Either you go radial or you go pedal.
Mm-hmm.
The reason why I think radial is preferable in this case is because of the size of the vessel, right?
Mm-hmm.
So there are, my assumption is we either do a device, like you use a atherectomy device and do a DCB, or you stent, right? Those are the two options left. So either ways, I don't think pedally is a good option, because if you're stenting this vessel size, it's going to be at least a 7 stent, and you have to put a 6-French sheath. Putting a 6-French sheath through the pedal vessels, I don't know if it's a very good option.
Well, we'll show you the anatomy.
Second is, if you want to use a device also to cut something of this vessel, it has to be at least a very large device, because it has to give a very good atherectomy result. Even then, you have to go with a 6 or a 7 French sheath, which is not a very good pedal option. I think that's where radial comes into play here, because first of all, you have more room to do stuff. You have the stent sizes and everything. You don't have a limitation of sheet size.
Well, the nice thing about Terumo is they have these wonderful sheets, right?
Yeah.
They have the 5/6 slender.
And now
they
have pretty much the whole array.
Go ahead, Vishal. You were saying?
No. I was going to be the devil's advocate and talk to Karthik about. So we could technically, I haven't seen the pedal shot, so I don't know how the below the knee vessels look. But I'm assuming if they look normal in a person, then you could technically go a 5/6 slender through an anterior tibial or posterior tibial, whichever has a good luminar size or whichever is more dominant. And then we can technically put balloon stents. We can also do atherectomy through them. It's possible. So it's a very decent and a reliable option going through pedal.
But let me push back a little bit on that. I mean, this guy's a claudican, right? He's not a critical limb. He's obviously a severe vasculopath. He has coronary disease. He has subclavian disease. He has vascular disease throughout. He's got occluded iliac. I don't care how robust those vessels are. Do you think the distal vasculature of the foot is the same as the hand?
Yep.
Probably
I'm
not.
talking about the microvasculature. So
Probably not.
how many patients with PAD have you done in your career where you see hand ischemia and hand gangrene? How many have you done with foot gangrene? And this, I think, Vishal, is an important point. I mean, obviously your point is well taken if you don't have options, but I think when you have other options like a radial option in this particular patient, you have to avoid the pedal option in a claudican. Everybody thinks the pedal vasculature is the same as the hand vasculature, and that is a falsity. There's multiple colleagues of mine who are very on the podium talking about approaches from the foot, which is absolutely the wrong thing to do in a claudican. I think if you want to get access to cross the lesions like we've demonstrated, we've done, by the way, this is our 101st live case. Okay, in our program. So let's think about how many cases have we done through direct pedal access, intervening through the pedal? 0. Right? And how many cases have we failed? Almost 0. So the point I'm trying to say is that I just think, Vishal, we have to be careful, because when we're saying to just get pedal access and intervene, even if he has 3-vessel runoff, I'll ask you a question. Do you know the natural history of access in the pedal as you do in the radial? Do you know? We don't know. That's my point. There's one paper by Thomas Zeller. Okay, I think was it Zeller or Mustafa? I can't remember. There's one paper that shows that there's no consequence of amputation. But the point is, they did an immediate post-op pulse examination, and that's it. Actually, it wasn't by Zeller. I think it was somebody in Florida. So this is the situation. So I think that you have to be careful by saying there's going to be no consequences of your pedal intervention. That's just, I just worry about that. Now there's one more choice, guys. What other thing could we do?
I mean, theoretically, you can get an SFA access and integrate. This is actually also a nice way to do the intervention, but then you are limited with the closure of this access site.
Right. Exactly.
I mean, here we are a little bit restricted with vascular closure devices in comparison to Europe, for example. But it would be a manual hold, and the risk of pseudoaneurysm in the SFA puncturing at a lower level will be higher. Second, the SFA dives deeper into the musculature at this level, so this might be also a little bit challenging, but also possible, and could be also a bailout. A bailout situation where you can have bigger sheaths and accesses there.
So Sardar, I'll did what Vishal did, devil's advocate, right?
Yeah.
I don't think SFA access is a good access here, only because there's a Fem-Fem. That's the only reason pedal is also not a very good option for this patient. The reason being because this lesion is proximal to the Fem-Fem, right?
Yeah.
So if you are trying to, by any chance, if you have the bailout option is to stent, the stenting, if you want to land the stent, landing the stent from radial is so much more easy and precise than doing through this SFA or pedals. So there's a chance of landing that stent across the Fem-Fem is so much more higher from a distal approach than a proximal approach.
I know. That's a very good point.
We're just discussing bailout options and alternatives.
Yeah.
No.
I just devil's advocate.
No, but I think Sardar, your point is wonderful, because I know in Germany, you when you were there, you saw them get a lot of SFA access for control, and you saw the pseudoaneurysms that occurred with over there. But I think that this is the point of collaboration. We get to talk about each thing. Now, let's talk a little bit about this. So what about contralateral femoral access going through the graft and then going up? Because like I could show you the angiogram. Let's show the angiogram now before we talk about that.
Principally,
first of all, I want to show you how we do this. Go minus. So I think one of the things you have to understand is the challenges of this particular intervention. Can we play this, guys? Ray, how can you play this?
I'm not sure if they may have been able to play
Oh, there it goes. Okay, so first it's very important, as we do in the coronaries, or we should do in the coronaries, we follow the wire all the way up, right? Because there may be a radial root. This is a super cold wire, very soft tip, no issues. As the wire comes up, I want you to watch. It's very important, okay? When it stops and then it goes through, and then watch, it goes right up into the vert. So it's very important to watch and not push the wire. Okay, so at this stage, when it's gone to the vert, we went ahead and switched out. Dr. Guja suggested a JR. I decided to go with a vert tip. I think any directional catheter is okay. Next one. So we went with the directional catheter. Oops. Okay, and we pointed it down. I guess we didn't. So we pointed it down. We got the catheter all the way down. Now at this stage, now you see we have to enter the stent. So we enter the stent. We're trying to probe with the catheter, and I'll show you the aorta. Actually, Raman showed you the aorta. It's a very dilated aorta with these two stents sticking in, so it's very difficult. So at this stage, what you want to do is try to engage the stent with the catheter. Now remember, it's a 2D image of a 3D plane, so it's all virtually impossible. So what I decided to do, and I think it's important for everybody, is try, rather than wire this, because it could get into the side strut, is to go with a J-tip wire. So we decided to go next, Ray. So we decided to go with an angle J, and what we did was we went ahead and the angle J went ahead and engaged something. We don't know. You'll see it now. So here comes the angle J. And it's very important to see how this works. So the J is not going to go through a strut, right? So the J gets behind the vessel, and remember the stents are sticking into the aorta, so it's going to get posterior to the stent there, we think, or maybe not. So what I decided to do is now, at this stage, you push the wire to show that it may be in the stent, and now you go to two different views. Next, Ray. So you go to another view, and if you go to the second view, you'll see that you're not, and then Ray will play it, and then you'll see how when the catheter goes in, it's important to watch whether the stent is getting distorted or not, which is very, very important. So here goes the catheter. You're on the soft part of the wire, so you could prolapse out. You need to be cognizant of that. And as the catheter goes in, you want to watch that stent. So you see, the stent did not deform, and now watch the wire. So the wire goes straight through. Now, next, Ray. So then once you're through, we go distal, and now we took a picture of our lesion that Raman so nicely showed here. You can really start to see the napkin ring sort of lesion there. Next. And then here's another view where you see it even better. You see it right there? So it's right at the bypass graft. So what Dr. Gujo was saying is very, very clear. Next, Chief. So then we decided to do a quick runoff to look at the SFA, and again to show you all the different options. So the SFA has some mild disease throughout. Next. And the below knee shows very good vessels, Vishal, like you were suggesting. But at the same time, I mean, I would not lose one of my anterior tibia if you ask me. Next.
No, but okay.
I just have to ask you a question. And here's the below knee. So there is some distal AT disease. So you can see the dorsalis fetus has some distal disease. So it's not a disease-free segment, right? So now we're here. Now we're going to go ahead, as you guys discussed, we're going to go ahead and start the IVUS. So actually, before that, Raman, while we do the IVUS, why don't you go over your presentation?
Yeah, of course.
Can I have the wire?
Before Raman starts, I think PK, we were just talking about why can't we use the bypass graft. Sardar, what do you think about using the bypass as an access site?
Contralateral access. I mean, for this lesion, I believe it's not ideal because the intervention site is gonna be at the exit of the wire from the bypass. So
what wire is this?
If we would do an intervention on the SFA, it would be actually a possible access.
Particore.
Yeah, it's like here you have to go retrogradely up, and the angulation of the graft takeoff or the stitch might be unfavorable to get your devices across, and then you might jeopardize takeoff of your graft. So now you're jeopardizing two vessels for one, and two legs essentially. So it's like one of the last.
And accessing the graft, Vishal and Sardar, what do you think about accessing the graft? Like, how do we access? How do we close? Sardar, Vishal, any thoughts? We spoke about it. I thought, we usually never speak about that.
Okay.
Sardar?
No. I have
manual
no
or
insights to that.
Fellow seal. The fellow holds it.
I know you have the most experience.
I mean, we've accessed grafts numerous times, and you can close grafts.
You can close grafts,
You can use per close. I mean, we've done per close in the Fem-Fem. I mean, if you were to personally, what the surgeons will tell you is, with a Fem-Fem, you want to stick the what is it called, the middle of the graft.
Correct.
Right. You don't need to stick the anastomosis below. You just need to stick the middle of the graft. So okay, that's enough. So I'm going to pull out the 035 wire now. We got plenty of access across it. So now we got the 035 wire across. We got this one across. Go ahead, Raman. Go ahead. Finish up.
Sorry for stuff.
No worries. No worries. All right. So, you get the slides back up, please. All right. So, as you know, there's a lot of discussion, and a lot of this was mentioned. So we'll just briefly summarize. In regards to the approach for access in this particular case, as well as just in general, when looking at cases like this, the options that were mentioned are the same ones mentioned here: a direct superficial access, a transpedal or transradial. Each of them, as we all discussed, have their own pros and cons. Direct superficial access one of the main pros is that a lot of the devices that are readily available in the majority of labs are readily available for the direct superficial access. So
that's great. I got it.
there is a great degree of convenience that the practitioners may have by doing this. But as the cons, as also mentioned,
Really?
the management of the access site is quite an issue. Manual just a manual hold has its own intrinsic risk of vascular complications, notably pseudoaneurysms, and closure devices are not really available for SFA interventions in the U.S. besides Vascades. Transpedal, again, one of the main pros that are notable is the fact that there is a marked decrease in the vascular and bleeding complications. But again, given the fact that these patients have severe PAD, claudication, there is a great degree of injury to the pedal vasculature, and at the same time, not across the board, not all the labs that are in the U.S. actually have the full capabilities and are equipped to perform pedal access. And again, pedal access, when performed, is generally used as a secondary access to kind of facilitate lesion crossing. Now, for our case, transradial access, again, is a decrease in vascular and bleeding complications. Patients generally like it because of the early ambulation and their comfort. And that too, again, it's a reasonable option for above-knee intervention as a singular option. But again, the cons also mentioned is the fact that there's no bailout option that could be available for covered sending for aorta-iliac intervention, especially to increase radiation, and the fact that we'll talk about this now about the number of devices available for below-knee intervention, and the DCB is not really coming in any shaft length greater than 135. And then the obvious technical challenges of radial access. Next slide. So just quickly, just to talk about the radial access issues, that were mentioned by Dr. Gujra, the spasm of both the radial and brachial artery, radial loops, and managing that that difficulty always makes antispasmodics very important to add into your cocktail when approaching from the radial access. Subclavian tortuosity, especially when going from the right side, can pose a significant difficulty and added technical complexity to any case. And finally, given the fact that, again, as we mentioned, the sheets stay inside the radial artery for a very long time. So the risk of radial artery occlusion is not an insignificant one. Next slide. So again, when discussing transradial access, one of the main things that we have to discuss about is the shaft length of the devices available. And that comes into play when you talk about how far all the lesions are from your radial access point. So aorta-iliacs are ranged from, depending on where you go from the right or left side, from the 100, 110 to 120 to 130 centimeters, and common femoral from there to about 150. And then below the popliteal, we're talking about generally 150 centimeters and longer. Next slide. So as far as the radial sheaths and the sheet that we use in this case, Terumo has their destination slender sheath, which comes in 119 and 149 centimeters in a 6 French size, which comes in very, very handy, especially for when you're approaching CTOs and need extra support very proximal to a lesion. Other, 25 or 16 centimeter stents won't really give you the same support you will need up front. And again, exchanging it over supercore the way how we did in this case, it becomes very important to make sure that any tortuosity along the way is appropriately managed.
Give me a large chocolate balloon.
So there's a lot of information on this, but in looking at the available PTA balloons from the radial access, the main thing to always think about is simply just the shaft length, and then also whether they're over the wire or a rapid exchange. The rapid exchange ones that are available are the Ultraverse, and the second one, which is not actually on here, is the Metacross, which I have on the next slide, which then markedly reduces the amount of overall wire length that you would need. The Pacific Plus comes in a shaft length of 180, but to manage that, since it's an over-the-wire system, you would need something along the lines of 360, 400 centimeters of wire. But again, the main issue for this is also
10
is also that these
And at the
balloons, if they
stenosis?
do have shaft lengths of the
And at the
135 to
stenosis,
150,
Karthik?
the distance after which they're also available should be used in the air to iliac system if going from the radial, also limited by their available bailout strategies, which are unfortunately lacking from the transradial
What's the
approach.
longest 035 wire you have?
Next slide.
400.
So this is the Metacross
I
balloon.
need it.
This is it comes to a 200 centimeter shaft length, and it's a rapid exchange system. So a regular 300 wire would, or a 360 wire would be more than enough to get this to a very distal, all the way down to the infrapopliteal system as well. Next slide. In regard to balloon expandable stents, they are again also limited by the availability of the long shaft lengths. So we're quite limited in that regard. Terumo has another stent that was recently approved by the FDA, but is not available. The Misago, I believe that's what it's called, but it's currently not available for use. That comes in a rapid exchange, right? The Misago, yeah, and that's also going to be available shortly. Next slide.
What's the shaft length of this balloon? Go ahead, you keep going.
Okay. And then in regards to the self-expanding stents, the longest one that is available is the Everflex. The Everflex is over here listed as 120, but there's the new Everflex Entrust, which comes in a shaft length of 180 centimeters. So that allows you to get that extra distance as well. But again, just keeping in mind always when you're talking about these interventions about the balloons and stents, is the bailout options, and the bailout options are really limited to 120, 130, especially when it comes to the covered stents. Next slide, please. So as far as the DCBs are available, it's, as mentioned numerous times, the inguinal intervention is very much limited based off the availabilities of the devices and their currently available shaft lengths, largely limited to 135 centimeters. So when planning a case, if you have an exceptionally short person, it may be a possibility to get more distal in the SFA, but for average size people, this would make it very challenging to do more distal SFA intervention.
It's not the Aquatempo.
Next slide. As far as atherectomy devices, there is actually a little bit more of an option as far as what you can do. The Diamondback 360 and the Hawk 1 are two notable exceptions to this shaft length limitation. The Diamondback orbital atherectomy with the 125 or 15 millimeter solid crown, both come with a 200 centimeter shaft length capability and that actually can go through a 5 French system as well. The Hawk 1S directional atherectomy comes in a 151 centimeter system. And the Jetstream and Rotolink both fall a little bit shorter in the 145 and 130 respectively for the Rotolink. Next slide. Finally, we'll briefly just talk about filters. There again, it's the same concept. The filter wire comes in quite long. The Spider also in 320. So there's a little bit more leeway, at least in regards to the use of filters, but. Again, this just comes down to your overall working length, shaft length, and the rest of your respective devices for your PTA balloon, stents, and bailout options as necessary.
This is one.
That being said, we conclude the rest of this presentation so we can get back to where we are.
So I think, Raman, I mean, that, for all of us in the audience, I mean, that's an incredible overview because that overview really tells us what are the options. So we have our Terumo gang here who is phenomenal, and I can tell you that they've been incredible in helping us pick out the wires and the catheters that we need. So before we get to that, let's go over the IVUS so I can give Vishal and Sardar some information regarding what's going on. So the intravascular ultrasound is going to tell you a lot. So Karthik, what did you find? Can you play the IVUS, guys, and show it to them?
Yeah. So the vessel size, guys, we got is 10.0, 9.9. So that's the vessel size proximal to the lesion. At the lesion, the stenosis is measuring at 68% or close to 70%, which is what is expected of it. And the vessel size itself is like 10
So this is interesting. So now with all the limitations that we've gone over, and that Raman actually went over the equipment, what are you guys thinking in terms of therapy?
It's a good question.
Well, yeah, I mean, so how far is the graft from the lesion and the IVUS? Do we see that or not yet?
The lesion is right proximal to the graft.
I think he's asking
pretty
for
much
like the distance from
So
the
distance is probably a couple of millimeters.
Okay, so it's almost abutting the graft,
Yeah,
right?
it's
Yeah.
almost abutting the graft.
Yeah, so I guess we have to be cognizant of the fact that the graft originates from there, so you have to give that due respect.
Yes.
So I mean, it's a tough call. I mean, I don't know. I mean, how
Atherotomy.
right?
Possibly atherotomy and maybe a
which is 8 or 20.
DCB if possible.
Okay, I mean, I don't know how aggressive you want to be. Atherectomy might be yes, might be no, depending on, because like you said, it's very close to the graft. So maybe an alternative like atherotomy might be a decent alternative in my personal opinion. But
So what do you think about the shaft lengths? We just talked to the Turmo people, and they told us that the atherotomy shaft length's around 120,
Yeah.
and the size is a 6. The largest atherotomy balloon is a 6. So that's an issue. So and also, I mean, what do you think? I mean, to me, atherectomy at this site, first of all, it's actually by definition probably an external iliac, right, at the level, because the inferior epigastric comes below this particular vessel. So atherectomy at the external iliac by the Silverhawk device is contraindicated.
Right.
With the CSI with a diameter of this vessel around 6, you're going to get no apposition. Although the CSI has a code for iliac, the Jetstream is not going to get you any apposition. It's a 2.4, 3.4 or whatever it is, and it's not going to get apposition. So atherectomy's out. So
what about shockwave?
Shockwave, again, you got a 7mm shockwave, right? And Karthik's IVUS didn't show us a lot of calcium. So to me, I think you have to kind of keep it simple.
Yep.
So the nice thing about Terumo's devices is you've got the what Raman went over so nicely is that they're all monorail. So a lot of them are monorail. I shouldn't say they're all monorail. They have the options. And the nice thing is it allows you to go work on any length wire that you need to work on and go. So I think in this, your therapy has to be based on the devices available. We're not quite at prime time where we have every device and every length, so we can say, hey, we can go radially with whatever sheet size to be able to treat this. So having said that, you see this image that's up there under the roadmap. You've got the lesion, and you can see that this lesion, though by IVUS is only 70%, is likely accentuated physiologically when the patient walks because of the vasodilatation in the beds, with the steal occurring from the left leg and obviously stealing from both legs. So therefore, this particular patient is going to be very ischemic with this lesion, with a PSVR of that Raman showed you around 370. So I think at this stage, we should balloon it. I'm not certain whether the drug-coated therapy will fit. We spoke to the Terumo folks. They felt that it possibly could. I have plenty of sheath outside the body. I can advance the sheath forward. So I've taken this longer glide wire that Terumo provides. We've jaded it and we put it into the SFA. Now I'm going to introduce the dilator and push the sheet down. So let's get the dilator.
You won't need it, PK.
You won't need it?
We won't need it.
Okay, Karthik feels we won't need it.
Because
Okay.
it's a 135 shaft, I think 135 will reach this. But the only question is if you want to pre-dilate with a Metacross balloon first before you do
I do, but I don't want to repeat myself, so I'm going to push this down. So give me the dilator, guys, because we're quite a bit away from that particular lesion with the sheet, so it's better to put the dilator in. So one thing I want to get everything prepared. I think one of the things that everybody at home is, it's you have to understand that when you move these radial sheets, especially these long sheets, or anywhere in the body really, if you're moving it in the iliac, you definitely don't want to push it blindly. You really want to have the dilator. You want to visualize. You want to prevent buckling. You want to prevent all that stuff, especially in this situation. You have stents across the iliac. You have a dilated aorta. So I want to watch my sheath, and the wire, Karthik is going to give me a good rail as the wire comes down. And as the wire comes down, I'm just going to watch my sheath. The dilator comes down. And as you all know, English is not my first language. And let me see here. A little rail, Karthik?
Yeah, I got it. I'm
going to need a wet one here.
Soft,
Oh, it's a stiff glide.
Yeah. No, I'm saying it's
a stiff glide.
soft wire.
Okay, sorry, senor.
It will reach, PK. All the equipment will reach. It's 135 shaft.
So we can also try to what's called as what's it called?
Yeah.
Telescoping.
Telescoping.
No, it's not going.
It's not going.
It's really not
It will
going.
reach, PK.
There's some
Okay,
radar
Karthik
to
feels it'll
spasm.
reach, so we'll try.
Yeah, I think in the common femoral external iliac, it'll definitely reach for sure. So you
Yeah.
have, even though you have outside, because of the proximity of the
you
lesion,
want-
you should be able to get it.
So one of the things we're going to do is we're going to use a Metacross balloon. Is it an 035 balloon?
Yeah.
Metacross balloon.
What size do you want? 820?
I'll do an 820 pre-dilatation. And this is a over the wire or monorail? It's a monorail balloon.
Monorail balloon.
It's a very cool 035 monorail balloon. I like that particular view that we had, which showed everything. Little digress. There you go. All right. So we're going to try to go right across it. God willing, everything will go well. So what are some of the bad things that can happen here? I really don't think much, because the only thing you have to worry about is plaque shifting into the graft, which I doubt is going to occur. Why you think it'll occur? Ray's shaking his head because he doesn't want that to occur. No, I hope not.
Would you ever consider putting a wire into the graft to preserve it?
I don't think you need to.
Huge graft.
I think you'll be okay.
I think the graft portion is okay.
I mean, there's a good.
Should be fine.
It's a good question Raman has. Do we wire protect the graft? I think
The only question is, if you dissect, what are your options?
Well, you have a Terumo
That's
stent,
it.
don't you?
Yeah.
So good. Thank God for Terumo there, yeah?
Yeah.
All right, here we go.
I think
Sorry. I'm just saying that I think the radial sheath is really a phenomenal tool. You could see, though, I think you have to place it properly before you go, because you could see when I was trying to push it, the patient was having a lot of pain. So therefore, am I already through it? Is there markers on this?
No. Keep going.
no, you're still far away.
Far away
Are
from
you sure?
Yeah, positive.
Oh, there it is. Okay.
There it is.
Positive.
There you go. I'm going to leave it right there, sort of half there, half not. And we're going to go up with this. We'll see if it slides.
Yeah, it's a very,
There it
Okay,
is.
spot
See?
right
There
there.
it is.
and you got the neck, yeah?
8, 6,
Still looks a little undersized, but yeah.
6,
Good
8.
size.
I mean, it's a 10 vessels.
8,
Right.
9, 10.
10.
Okay. Would anybody use a DCB here?
I would probably go with
Okay.
the DCB.
Okay.
Oh, my only question is, if you say a vessel is an 8 or a 9 and you put a 7 or DCB,
Exactly.
how much
So,
are you going to go up on the DCB to really oppose onto the wall and drug delivery?
I'm not going to use the DCB down. I totally agree with you.
Yeah.
Let's get a 10-0 balloon from Terumo if they have it.
or you could be, well, it's a 6 French, 2-1.
Okay, no
You could
balloon.
put 2 balloons on this side.
Yeah, that's
Create a
true.
bigger.
8 is the biggest they have.
You got to go double negative.
No, I think she said you have to just go neutral, actually.
No.
to
Come forward,
pull
please.
it out.
Negative now. Push forward.
No.
Negative, please.
I did.
Having a lot of trouble with the balloon coming out here.
Okay.
So neutral.
I think it probably just takes a little bit of time to deflate.
Float up.
Look at the pressure.
Float up again.
Off roadmap.
I did.
Okay, AP. Cycle a cuff, guys.
Want to take a puff? Let's see.
Yeah. Okay, everything looks good.
Yeah, flow is good. It'll come out. It's always a little
So
difficult. when you
PK,
pull it out.
just a quick overview.
just
So
have to be a
in
little
case
bit
the
more
vessel
careful.
size was not that big enough, let's say it was a 6 or a 7-0, what atherectomy, if you would have decided to use, would be your choice?
Got it. I got it.
What's that, buddy?
Let me ask Sardar. Sardar, if the vessel size was not, let's say 8 or 9, or let's say it was a 6 or max 7-0,
DSA?
and if you had to choose an atherectomy, what would be your atherectomy of choice?
Probably a CSI or a Hawk even.
But in this area, I don't think you can do any of that, guys. I mean,
No,
it's-
I'm just talking about hypothetical. If the vessel size was not
Totally.
that big enough, that's my question. In case somebody,
Oh, you meant it was off.
Yeah.
Sorry. Karthik is teaching me angiography. I forgot a long time ago. To me, I don't think this is something that I would worry about. I'm just going to go ahead with a larger balloon here.
right?
Give me a
Just get
give me a
any
9
balloon which is 135 shaft. Yeah. The 90? Or 10, give
Give
it
me
9.
another
Wet,
another wet one.
940. PK, you'll go with 9 first, right?
I
Yeah.
think yeah,
10.
9 is a good idea.
10 is a little bit too much, no? I think we got.
I think we just want to go
decent
slow,
result.
upgrade it, so that way we don't cause. We have controlled dissection
Yeah.
of the place rather than causing extensive trauma.
Mm-hmm.
One second.
You gotta wet the wire, I think, on
Yeah,
the back.
it is.
In the back end, you have to wet the wire. So I think it's interesting, with Terumo wires is, you got to wet them. So you can see that the balloon, we're having trouble getting the balloon out because the back end is not wet.
Right.
So wet the back end where
we did, we
you
did.
did. Okay.
I mean,
got
the
it.
lumen definitely looks bigger. So, I mean, it's a. We can of course go on a 9.0 balloon, but it's a. I mean, you definitely had some luminal gain for sure after that PTA. So at least that's good. And the graft looks great as well. So far we're doing great.
Yeah, I mean, I think we'll do this. We'll do an IVUS, and then again, like I said, we're looking for physiological improvement here, not anatomical.
Why?
So yep, and I think this will really help us. So guys, when this goes down, let's keep the wire wet.
Yeah.
Okay, rail.
Yeah.
Like. So the other thing also all of us have to be cognizant about is that it is a glide wire distally, right? So you have to worry about what's happening distally as well, right?
Any reason you're using glide and not like a supracore or any of the stiff wires, even though they have the length?
This one doesn't have length enough.
No, it will little. Half a little bit. Half a little bit.
You can push the sheath over it and try to see if you can glide the sheath over it and you'll get
No, it's not quite reaching. Interesting.
Short push it. That's it. You got it.
I don't know. Let's go. Let's
see the previous picture.
let's go previous picture.
Oops. It's very close.
No, it's
No,
freeze now.
it's on the lower end of the femoral head.
Yeah.
So. You might have to track your sheath in a little bit if you have the sheath area outside.
No, it's not going to go.
We can exchange it to supracore and push it. It'll give you. Try to push the sheet now.
Can you track your sheath over the balloon, PK?
Yeah,
No?
I will.
It's too stiff.
I'm a little
You're
worried
concerned?
about that.
Okay.
Yeah, he's having a lot of pain when we were moving it. Let me
Oh,
see.
okay.
Probably
Rail-
from the
rail-
from the
spasm.
Rail the
spasm,
balloon
yeah.
goes?
Yeah, rail the balloon and see. There we go.
Have a lot of pain.
And I'm sure spasm
That's
like
good.
we talked
That's
about.
good. That's good enough, no?
That may be good enough.
Yeah.
Nope.
Really?
Yeah.
He's having too much pain. I mean, the guy's
Just
really
Probably the
Wait.
slack in the aorta is probably giving you that.
Yeah.
It's just
I don't
The
know.
supracore wire and then do it.
Just
Probably
another
that?
5
the
millimeter.
reason is probably the wire, PK. The wire is too flimsy for.
This
pushing
is
it.
too
Yeah,
flimsy?
Yeah.
Okay, give us a supercore wire.
Supracore wire. You'll get it. Once you put a supracore, you'll get it.
Right, Pacific Plus. So the Pacific Plus has a 180.
Pacific Plus is 180, but
Yeah.
there's no 90 in Pacific Plus.
Yeah.
They only go maximum.
So you can see the challenges we are having with this. But you know what? I'm telling you, I may leave it the way it is because I think we've gotten a good result here and not go too crazy. Let's see.
Yeah, you're right. It's actually getting the physiological improvement and not the looking at from the angiographic perspective.
Mm-hmm.
Okay, now try it.
All right, see, super good.
Let's go AT. Okay, guys, give me a wet one here.
One second.
Yeah, you're right.
Actually.
The radial spasm is, I guess, your biggest limiting factor.
A lot of pain. No, I can already feel the resistance.
Now try it.
It's no joke. He's having a lot of
That's it,
resistance.
no?
Nope.
You're good. You're good.
Lower bottom of the femoral.
No, I think you're almost there.
You're
yeah.
good, no?
You're there. I
Give me-
think you should be good.
Give me a little die.
Yeah.
Yeah, we are
Across the
there.
graph, no?
No.
Yeah, across
Okay,
the
that
graph.
might be enough.
Yeah.
Okay, go up there.
A little bit more. No? Okay.
No, I think
There's
we're
no more
across
to
the
go.
sutures.
There's no more to
Oh,
go,
okay.
brother.
Oh, okay.
There it is. We got it. Careful.
Four.
Maybe with the balloon up, we can push it down.
No, don't.
Mm-hmm.
I think we got it. We have more than enough room. I think it's right in the middle of the balloon. Actually.
Okay, down.
Yeah,
Nicely expanded.
Yeah, the balloon expansion as well. You could see that it's not deflected to one side. So it
Ready?
should be good.
Mm-hmm. Go ahead, walk it out.
Remember, when you walk it over, the wire is only 300.
Mm-hmm.
So you want to put your wire?
Nah.
No, it's okay.
If we lose it, it's okay. Mm-hmm.
Just, yeah, push. The only thing again, I think you have to watch out for is it's very hydrophilic sheath. So when you're getting your balloons in and out, the sheath might come back a lot. So that's one thing I think we have to watch out for.
Good. Okay, ready for picture?
Mm-hmm.
Give me a syringe, please.
Right here.
He's got it. Come forward. Let's do a DSA.
Thanks.
Okay, oh, looks great. Ready?
You want to do IVUS?
Okay. It's filling.
Good, good.
I think it's a lot better than it was.
Mm-hmm.
I think that's all we can do at this stage. I think we definitely need to do an IVUS and then see how that looks. If it looks a little bit better, we're done. We'll watch for recoil. Let me just make sure, the other thing I always want to tell everybody, with the Terumo wires, as good as they are, you have to be careful with them. Make sure there's no issues going on as we go ahead and take pictures below. So let me make sure that we didn't have any issues with the Terumo wire as it was going elsewhere.
Looks good.
Good, yeah.
Mm-hmm.
You want to give some nitro?
We will at the end. Refill it, please.
Yeah. Can you get some more contrast, please?
Want to put the wire in the meantime?
Let's
You
just.
can exchange it for an overnight and then do another.
So while we're getting the contrast ready. Any other thoughts, Vishal?
No, I mean, you're right. I mean, we had some luminal gain. If anybody has any doubt, you can do an IVUS just to document your gain size. You could also do a pullback pressure gradient if you're really obsessive about things. That might give you an indicator. But I think here we have enough. The idea is just to improve the blood flow. It's not about getting angiographic perfection. It's all about getting physiological perfection, I guess. So I think you're right. Being more aggressive might tilt the balance to the other side. So
Yeah.
I think it looks good. And we take some pictures, do an ending IVUS, and then decide. What do you think, Sardar?
Absolutely, I agree.
Well, the only other question is removing the sheath. Is there any concern for radial spasm?
Well,
How do you deal with that? So on and so
definitely.
forth.
In this case, I'll definitely give him more sedation. I think the first thing of radial spasm is sedation, sedation, and more sedation.
So Liz, let's sedate him to Liz.
You have
And
to
maybe some spasmolytics as well
Correct.
before you start
nitro.
pulling the
Nitro on the
nitro,
forearm.
Yeah.
So you want to give nitro through the side port or something, or just?
No,
Where just put it
just
like on the forearm.
yeah.
Just pull it until the arm and just give it.
Yeah,
before
but
pull
you
it
know
out.
the BK's question is right. You pull it up to the arm, but pulling till the arm is the most painful part
Yeah.
because as soon as you start pulling, he's going to
Yeah,
feel
yeah,
it and
yeah,
he's going to go under more spasm.
No, I meant
You can always give them a
systematically.
sublingual nitro,
systemically.
so-
Yeah, or some
Yeah.
transdermal or something.
So let's give a sublingual nitro, Liz. Okay. You know, guys, I'm going to bag the IVUS because I think at this stage, with all the spasm that's going on, I'm going to go ahead and just get an ultrasound post. It's not going to change my therapy in any way.
Okay.
You know, I'm not going to stent it. So at this stage, with the spasm and everything that's going on, I'm going to stop here. I'm going to Raman and I will get an ultrasound for him, and then we'll make sure that that everything looks good. So you can see there's good flow to the foot still, and that more importantly, there's no wire perf with the Terumo. So I think at this stage we're going to put the dilator in and walk this out. Ready? Dilator. Let's drop the tape a little bit. Where do you drop the tape? Oh, here it is. Okay, good. Good.
Yeah.
Well, I think you can wake him up and put it under his thumb. No?
He'll wake up when we start pulling the sheet.
Go wire.
Mm-hmm. Okay. So very smooth.
Nice. Yeah, that's the best thing about
Tell me
radio.
above. Well, it's yes and no, right? I mean, we've had
Right.
we actually did a radial carotid where we avulsed the radial. So that's not true. Show me above. Okay, stop there. Let's pull the wire back a little now. So it's interesting. It wouldn't advance in, but it comes out very smooth.
It's,
Very interesting to me,
probably
honestly.
because of the stents also, we are having issues with that.
Well, the angulation of the iliac also is playing against you, so that's why you have to use a stiffer wire to just change the angulation.
We can give some. We can give some
Good.
lights here.
All
But
right.
I'm sure Liz
So
probably
I
gave
think
her some.
I think Vishal, Karthik, I think, and Sardar, I think we're going to call it here. I want to thank our good people at Terumo for coming and supporting this case. As we all know, we don't do a lot of these, and I know that they want us to do more, and we will. But I really appreciate them coming so early in the morning and helping us. But I thought it was a great demonstration of the products that are available with Terumo, the wonderful length of the sheets that are available with Terumo, as well as the balloons. We also learned along with all of you that the glide wires are great, but you got to keep them wet. The balloons track really well, but the sheet, obviously, I think the sheet position has to be in the ideal position prior to you starting your intervention, because when you're trying to push it, the patient obviously is going to feel a lot of pain as you're trying to push. One push is better than 2 or 3 pushes trying to readjust. So probably get the sheet that's close to the lesion, and as you just saw, it's easy to pull back. It's probably harder to push in. I think the Terumo people would agree with that. Maybe they're much more experienced than us. But here, you had a nice discussion on regarding which of the access points, the pros and cons of all the access points, and also a treatment of a lesion that was really very physiologic, although anatomically was only 70%. So I think at this stage we treated with a plain old balloon angioplasty. We know that balloon angioplasty in the iliac segment does really, really well. So I'm not concerned in terms of restenosis. As far as anticoagulation, we'll do exactly what we talked about. We'll do Plavix and Xarelto because that's what he's been on and he's been stable. We will follow him with ultrasounds in the post, and then we'll see you. So I appreciate all of you tuning in. I appreciate those who will watch this soon. Please send us your questions via the app and also via the website. And you can also see us on ViewMedi as well as the YouTube channel. So we'll see you here for next month's live case. And I thank Karthik, Raman, Ray, and Elizabeth, as well as all both of you and everybody in Terumo. So thank you again, you guys.
Thank you.
Thank you.
Thank you.
You good? You okay?
All right. Thank you, PK, and thank you, viewers, for joining us. As we summarize, we'll be back again next month, August 26th, 8 o'clock Eastern Standard Time from Mount Sinai Hospital in New York City. Till then, please be safe, take care, and good luck to everyone and their families. Thank you.
Goodbye.